This video is going to explain the Frank-Starling law. It can be very intimidating at first, but what I circled in orange this basic first take a 15-second breath and look at this. This is your perfect Frank-Starling curve. Your cardiac function curve is here. Your vascular function curve is here. And this green dot is the place we want to be when the venous return or equals preload or the venous return. That is 100% efficiency of blood pumping throughout the body's vasculature. Now, there are two things that make changes in the direction of the Frank-Starling curve, and that's changes in inotropy or contractility of the heart, and changes in preload or vascular resistance. There's also another one here. I added changes in TPR. This is a little more complex. This is if you're going for the 250s, and it's just important to realize that these things interplay with each other, but for basic science purposes, you want to know, as I'll explain, for instance, 1. So we know 0.1 is above the cardiac function curve. As your venous return increases, you have more end diastolic volume and cardiac output to pump, but it eventually flattens out because you can't just keep adding fluids to the body and expect more cardiac output, because at some point your heart can only contract so much. So 1, what is 1? 1, so we see here for the same amount of venous return, we're getting the same amount of end diastolic volume. For more venous return, we're getting the same amount of diastolic volume as in the normal one here. So venous return. So with the normal cardiac function curve, for this venous return, we should get this end diastolic volume. At 0.1, we have more venous return, but still the same end diastolic volume. So just thinking through this logically, how can this happen? Well, it happens by an increase in inotropy caused by, could be caused by exercise, epinephrine, norepinephrine, illicit drugs such as cocaine, digoxin. Basically, the left ventricle is pumping harder to get the increased fluid with each heartbeat. Now let's look at 2. A good way I like to think of it is I always like to take 10 seconds to see what's going on here. So we already know 0.2 is below the cardiac function curve. So we have less venous return. for the same amount of end diastolic volume. So see here in normal, we have this amount of venous return and this amount of diastolic volume. And at point 2, for some reason, we have less venous return, but we're getting the same amount of end diastolic volume. So this happens in uncompensated heart failure, opioid overdose, and a decrease in inotropy. So you have all, and this makes sense because how your cardiac output obviously is decreased, so your heart is contracting less forcefully and not getting as much cardiac output. So that's what heart failure is, and you're basically ending up with a higher end diastolic volume due to negative inotropy. Now three we see here it is actually right. So now we're looking at what happens to the Frank-Starling curve with changes in venous return. So here we see it's at the cardiac function curve, and we see for the venous return, we're getting the appropriate amount of end diastolic volume. But notice it's above the vascular function curve, and that is because you have more venous return than with the normal curve. So things like an AV fistula, an IV infusion. So let's say you give a patient a liter of normal saline. You're gonna raise them above the vascular function curve because you're adding total body fluids, but assuming that they don't have any heart failure or anything like that, it's going to eject the same amount of cardiac output, leaving the same end diastolic volume. Now let's look at 4 here. 4 is below both the cardiac function curve and vascular function curve. Now you already know, okay, now look at this. We got so little venous return and we got low end diastolic volume. This is really occurs in active hemorrhage. Spinal anesthesia, that's if you're going into anesthesia, you can figure that one out. Probably has something to do with decreased sympathetic activity due to administration of fentanyl into the intrathecal space. That's beyond the level of knowledge you need to know for step 1, unless you're going for a 250. Let's go here. 5 is below the cardiac function curve and the vascular function curve. So you have way less venous return, but your end diastolic volume is the same as normal. So basically, the only way that this can happen is vasopressors by increasing chronotropy. The only way they'd ask you question 5 is if they say patient massive hemorrhage receives a vasopressor, where would you expect the Frank-Starling curve to shift? You'd expect it to shift to the right because you're giving them a drug that's going to increase their inotropy. Sorry, I said chronotropy before. It's going to increase their inotropy to be able to pump more end diastolic blood out. 6 is above the cardiac function curve and above the vascular function curve. So you'll notice that you have more venous return, but you have less end diastolic volume. So when would this happen? Again, this is where the interplay comes in. It could be exercise because your heart rate goes up. You're going to have more cardiac output to perfuse the tissues. Your heart's going to be pumping with more. Your inotropy will increase to have the same end diastolic volume to get the maximum cardiac output out. But it can also happen in an AV shunt if you get arterial blood going into venous circulation, increasing your venous return. Moving on to 7. 7 looks really bad. That's because it is. You have no cardiac output. And why in ventricular fibrillation you have no cardiac output? That's because when your heart rate is 150 to 500, there is no diastolic filling time. You can't fill any blood into the left ventricle, therefore there's no blood to pump out and your cardiac output is 0. That's when you get the crash cart and begin to do